All right. Thank you, Monica. We appreciate you for being such a great classes coordinator and just are so appreciative of the co-op for having this resource. And thanks for being here. I'm Dr. Wood. I'm a naturopathic physician with Tummy Temple and primarily practicing out of our Lacey location, but we do a lot of telemedicine as well. And helping people with hormone balance is one of the areas that we love to work in. And so, yeah, we've got a lot of great information to go over today. Like Monica said, we welcome questions. You can unmute yourself and ask, or you can type it into the chat. I think probably it's yeah, if you, well, everybody's got their cameras turned off. So, just as far as the recording, the chat maybe is a little bit more private. But I also specialize in all manner of gut health conditions, allergies, autoimmune diseases, and mold illness. And I will pass it over to Dr. Dowdy to introduce herself.
Thank you. Um, Welcome everybody. We're excited to be here. I also practice in our Lacey location and provide telemedicine services for patients. And I have a passion for hormones and supporting people through changes in life that involve the endocrine system and hormones. And today we're going to spend some time talking about the transition of menopause and looking at it as this normal transition that all people with ovaries. All women are going to go through this. It isn't a disease state or a disorder. It is a accumulation of the end of ovarian production over the reproductive years. And what happens hormonally is we get declining levels of estrogen and progesterone, and even commonly testosterone levels in women. Technically, the definition of menopause is when periods have ceased for an entire year. And on average, women reach this point at age 51. Most go through a perimenopause, which is usually anywhere from age 45 to 55, and it can last, 7 to sometimes 14 years and start in the early 40th decade. That perimenopausal time frame is also, again, a normal transition where we start to see these trends in the hormones decreasing, which don't always happen in a nice linear fashion, which is often what drives symptoms that people are experiencing. So, an interesting fact with menopause is that women who have had their periods through age 55 and later, there is an association with breast cancer risk and just cycling that late in life. And again, that's just the cumulative exposure of hormone sensitive tissue from estrogen. Uh, Common symptoms associated with menopause can be hot flashes, often intense, night sweats, sometimes paired with just general insomnia. There can be mood changes like anxiety and irritability. And then there's often localized genital urinary symptoms like vaginal dryness, pain with sexual activity, and even urinary tract infections. And a lot of the time, these symptoms can be kind of a condition of, Western society and maybe some lifestyle, diet, fast-paced, habits that people have. And it's not a requirement in menopause to suffer at all. So, the most common symptom patients often complain about, and that has been well studied, is hot flashes. And that's because about 80% of women who go through menopause are going to experience hot flashes. And typically, hot flashes will cease on their own about 10 years after the end of cycling and having periods, even without intervention, because the body's going to adjust as the periods have ceased. So that's a little overview.
So I'm going to go a little more in depth into factors that contribute to having a lot of these symptoms, because as Dr. Dowdy said, it's not a requirement of menopause. There are women who kind of just sail through, and it's just it's the hormones change, but there's not this big upheaval of symptoms. And it does seem to be more women living a Western lifestyle that get really bad symptoms, whereas, research on women living like a hunter-gatherer lifestyle, which, there are still communities and tribes living a traditional lifestyle today, they tend to have a lot less of this. So, one of the big factors is a less active lifestyle. So, menopausal symptoms at every stage are decreased in very physically active women as compared to those who are less active. So, sedentary lifestyle likely to make a really big difference. Chronic stress and adrenal dysfunction. So the adrenal glands are these little kind of triangular glands that sit atop our kidneys like little hats, kind of deep in the abdomen or up against the back of the body, and they make small amounts of sex hormones. So in a healthy state, when the ovaries go into retirement, the adrenals can take over enough to help ease a lot of these symptoms. However, when we're really stressed out and the adrenals are really taxed, that tends not to happen so well. Um, and then exposure to environmental chemicals can make a really big difference. So there are many, many types of environmental chemicals that are termed endocrine disrupting, which means that they negatively impact our hormonal systems. That includes chemicals like BPA and unfortunately, probably almost certainly BPF and BPS, which like when you're grabbing a can of beans or tomatoes or whatever, or a plastic water bottle or something like that, that advertises that it's BPA free. It may mean that it's a different type of plastic than the type that has BPA in it, but it also could mean that they've replaced the BPA with one of these other BPF or BPS, which are almost certainly just as bad, maybe even worse, but just we haven't had enough time to study them. So that's kind of like a greenwashing thing or a kind of healthy washing thing that happens a lot. So BPA, hormone disrupting, as well as phthalates, which are in a lot of plastics and a lot of other sources as well. Phthalates are also found in artificial fragrances, so added to body care, skincare products, scented plugins, dryer sheets, laundry detergents, etc. And then pesticides. A lot of types of pesticides are hormone disrupting, as are flame retardants, and really a lot more, more than we can fully get into today. Um, and then oxidative stress from these exposures impairs ovulation and can result in early menopause, among other hormone problems like infertility, painful periods, and endometriosis. So, as I kind of briefly touched on, our hunter-gatherer ancestors and those still living a kind of hunter-gatherer traditional lifestyle today suffered really minimal or no menopausal symptoms in a lot of cases due to very active lifestyle, much lower exposure to chronic stress, and environmental chemicals. So they kind of had much better situation on all three of those levels. Low estrogen levels in menopause results in an acceleration of osteoporosis, cardiovascular disease, and cognitive decline. So estrogen does a lot for us. It can really, you know, it plays a huge role in helping us be strong and robust and healthy. And so having that drop off dramatically does contribute to kind of a downward slide on some of these areas. And then having more intense hot flashes may be an indicator actually of cardiovascular disease. So, someone that's having really intense symptoms, it's not a bad idea to talk to your doctor about maybe doing a bit of checking in on your cardiovascular health to see if there's a connection there, because that has been found in research.
Great, thank you. So I'm going to dive a little bit more into just the different categories Dr. Wood mentioned as far as contributors to symptoms in menopause. The first one being exercise as a lifestyle factor, specifically to reduce hot flash severity. Some studies have shown that regular exercise defined as moderate intensity, so things like cycling, jogging, vigorous hiking, exerting yourself to the point where it's maybe challenging to have a conversation, we'll call moderate intensity. Doing that 4 to 5 times a week is suggested to reduce hot flash frequency by 60%. So that's 45 minutes, 4 to 5 days a week, moderate intensity. It's a great goal. Identifying triggers, which are commonly alcohol, and within that, especially red wine, sugar, refined sugar, red meat, and spicy foods. Those are most common hot flash triggers. And a lot of that is just due to their effect on the vascular system, excuse me, because the hot flashes are driven by vasomotor instability, driven by the lack of estrogen. There are also botanical herbs that can be used even in perimenopause so that time period before, which can be a decade, just to support the decline, to maybe be more linear and gentle in its slope. Things like vitex, which is the botanical name for chaste tree berry, and wild yam, those are both helpful for progesterone and supporting progesterone levels. Is also maca root, black cohosh. Maca root is great at supporting the brain communication to the ovaries and having that system be balanced. So that's the hypothalamus, the pituitary, and then the ovaries. There's also herbs like red clover, dong quai, black cohosh. A lot of them are plant sources of plant-like estrogen compounds. They call them phytoestrogens. Those can provide estrogen support through daily use of the herb, whether it's tincture or tea or capsules. And then because of the connection with the adrenal glands and their ability to kind of take over some of the production of sex steroids in the perimenopause and menopausal transition, supporting your adrenal glands can also be helpful. And then we also have mood support. So there's lots of various amino acids that can help with either anxiety or depressive-like symptoms, irritability. I mean, the mood changes are so unique in menopause, and that's because everyone's got their own brain chemistry and neurotransmitter balance that is unique to them. A woman experiencing more depressive-like symptoms could benefit from 5-HTP. It's an amino acid, a serotonin precursor. It's important to know that you shouldn't combine something like that with a prescription antidepressant that's of the same mechanism. So those are SSRIs, an example being something like Zoloft or sertraline. There's also L-theanine. Theanine is this compound found in green tea. It is a very calming compound and can help balance an anxiety state by supporting GABA in the brain. And then we have things like ashwagandha, which nourish the adrenal glands and just help lessen the effects of excess cortisol or stress on all of the tissues in the body. And then usually the emotion of anger or rage and irritability is due not necessarily to enormous amounts of testosterone, even in women, but more the ratio of estrogen decreasing relative to the testosterone still staying present at higher levels. So it's a ratio issue. And we see that a lot too with the ratio of estrogen and progesterone also, especially in the perimenopausal lead up to menopause transition, where someone often needs some progesterone support.
I just shared a link in the chat that is to our product collection. So just some of the things we're talking about right now, if you want to check them out, they are there.
Thank you for that.
All right, of course. Okay, so I'm going to go a little bit into bioidentical hormone replacement therapy, who it's appropriate for, and discussing safety. So, in conventional medicine, what is typically offered are synthetic hormones. So they are similar to what our bodies make naturally, but they're not the same. Typically, that is a medication called Premarin, and that's the estrogen compound, and then medroxyprogesterone, and that's the progesterone-like compound. That one's a bit more obvious. And that's what's traditionally been used, and that's what was studied in the big studies that gave hormone replacement therapy a bad rap. So the World Health Organization study in 2002, which, a lot of people are not, like, it's not, most people have not read that study, but most people have heard some scary things about hormone replacement therapy. And so that's where that comes from. So the study was conducted on a very large number of people. It was I don't remember the exact numbers, but at least tens of thousands, if not more. It was stopped early because of an increased rate of breast cancer risk and cardiovascular disease in the people receiving the hormone replacement therapy, and that was the synthetic hormones. Um, in 2022, there was a meta-analysis, which is like a kind of a broad look, a different type of study that looked back at the one from 2002 and found a lot of flaws. And over decades of study, it has been found that these synthetic forms of estrogen and progesterone, they do increase risk of heart disease and breast, uterine, and ovarian cancer. So initially, it was thought that those same risks applied to bioidentical hormone replacement therapy. So that's where we're using, it is still in a hormone delivery form. So it's like, being given from outside the body, but it's estrogen that is exactly the same compound as what our bodies make. Progesterone, that's exactly the same. Um, and over the past, so it was assumed that those contained the same risks of cancer and heart disease because there hadn't been time to do studies on the bioidentical types to see if there was a difference. But fortunately, over the past 10 to 15 years, there have been numerous studies looking at bioidentical hormone safety, and they do not carry the same risks. So um, that has been kind of slow news to get out to the world and make it to a lot of doctors. And I think that's a really sad thing for women because it's a really great option. It has a lot of benefits, which we'll chat about. So, for example, natural or bioidentical progesterone results in a decreased risk of breast cancer compared to not using any hormones, where synthetic progestin or medroxyprogesterone increased risk of breast cancer by 40 to 69%. So that's like a massive difference between those two compounds. Synthetic hormones seem to almost like waste the body's energy by giving these incomplete and sort of wonky messages to our cells. Um, and then that fails to produce a balanced hormonal response. And they are also associated with a worse side effect profile. So even without the scary risk of cancer or heart disease, they tend to just have more benign but bothersome side effects as well. So, conventional medicine standard of care recommends hormone replacement therapy for women who are experiencing hot flashes. 85% of women experience them at least in our society. Mood disorders, such as depression and anxiety, sleep disturbance, and that typically goes along with a progesterone deficiency or imbalance where, at least ratio wise, there's not enough progesterone. Um, Hormone replacement therapy is indicated for joint aches and pain, which typically goes along with a deficiency of estrogen. For vulvovaginal symptoms such as vaginal dryness, vaginal pain, um, urinary tract infections or propensity to get them, increased urinary frequency, urinary incontinence, or like losing urine with coughing, sneezing, and laughing. And then that is because the pelvic floor muscles have estrogen receptors in them, in the bladder and urethra. And so when the estrogen levels drop, um, that plays a big role in the health and normal functioning of those tissues. And then hormone replacement therapy can be helpful for cognition, memory, bone density, cardiovascular disease prevention as well. So definitely let us know if you have any further questions about that. But I feel like that's a really important thing to make clear that the bioidentical hormones are much, much safer and, in fact, even do some of the opposite things. They actually seem to reduce cardiovascular disease risk and reduce cancer risk. Um, and then in direct opposition to the synthetic hormones. And then the other thing is because of the risks that were associated with the synthetic hormones, it was recommended that you could use them if someone was having hot flashes or some of these symptoms we've been discussing, but you were supposed to stop them as soon as you could, but absolutely after 10 years. That does not apply with the bioidentical hormones because the risk profile is very, very different.
Mhm.
And in fact, starting bioidentical hormones earlier or before menopause is associated with risk reduction of all-cause mortality and cardiac mortality. So that's uh, that's a pretty remarkable benefit. And then that benefit actually was not found for people starting hormone replacement therapy later after menopause. So there actually is, this really potentially wonderful benefit for starting sooner.
Awesome. Thank you. So I'm going to talk a little bit about contraindications, so maybe considerations to have for safety using HRT. And we'll say there is no actual condition or diagnosis that is an absolute no to hormones as long as the potential risk is understood. So we absolutely proceed with caution when we have a patient who has a history of ovarian cancer, endometrial cancer, any really gynecological cancer, melanoma, breast disease, or patients who have BCRA mutations, so BRCA gene mutations, excuse me, a family history of breast cancer, especially in first-degree relatives, proceed with caution. History of blood clots or varicose veins or circulation challenges, a history of fibroids or current fibroids, and then endometriosis. And a lot of the time, those conditions I just listed are driven by estrogen or progesterone and can occur in premenopausal years, commonly between the ages of 20 and 40. So these are just considerations to have, and you would want to be discussing those things with your healthcare provider team to really understand, well, what are the risks versus the benefits in particular to you, and then just discuss how you might modify your HRT plan and choose the delivery method because that matters. And we'll go into a little bit about that. There are various ways we can bring hormones into the body postmenopausally. Women are living 40 to 50 years longer than our ancestors did. Our bodies are outliving our hormones, really, in the grand scheme of how long humans have been around. Lifespan, only went into the 50s 500 years ago, which isn't that long ago. So we are living so much longer. And these hormones we're talking about today have so many other effects in the body besides the reproductive organs, as Dr. Wood was just going through. All of the brain has receptors, connective tissue has receptors. Estrogen drives and supports collagen production, elasticity. So many other symptoms can be affected by just the transition of menopause, and can be a reason why someone is just more sore and stiff and tired. So when considering what are the options for delivery, we have oral hormones, so a capsule or a pill you take by mouth. We also have topical hormones, meaning they go on your skin. And within that, there are creams and gels. There are also patches that are applied. And each delivery method has a different risk or benefit. And again, talking with your naturopath or one of us if you need one, to assess like what are your specific goals, what are the symptoms you're struggling with. We help patients every day identify what would be the best delivery method in their HRT. One of the reasons oral medications aren't for everybody is the fact that hormones, when you take them by mouth, have to pass through the liver. And there's this metabolism that occurs and it changes the initial hormone given, which might not be good for everyone to take. Bioidentical hormones don't cause breast or uterine or ovarian cancer, but there are some synthetic hormones, as Dr. Wood just mentioned, that will increase that risk. So, and that was the Premarin and the medroxyprogesterone. Interestingly, when we look at breast cancer rates in women after age 60, that risk goes up based on your biological aging. So it's interesting that supplementing with bioidentical progesterone decreases this breast cancer risk because part of the risk is just aging. So, and maybe potentially this connection with the hormones going down. There of breast cancer diagnoses, 75% of them are hormone sensitive. And again, that Women's Health Initiative study found that a higher breast cancer risk in women who were using synthetic estrogen Premarin with medroxyprogesterone acetate versus just the women who were using Premarin alone. And that study from the early 2000s. Dr. Wood, I pulled that statistic when you were talking, but that included 170,000 women that were put into different clinical groups. You know, some had just HRT, some had lifestyle factors. A whole group of them were observed a whole decade after the study was closed. So that I think that was almost two-thirds, like close to 90,000. And again, that was all on synthetic hormones, and we know so much more about bioidentical hormones now. So,
Great, thank you.
yeah.
Okay, I'm going to go a little bit more into cardiovascular disease risk. So, risks, factors that increase cardiovascular disease risk include early menopause, including early surgical menopause. So, having a hysterectomy, especially that complete hysterectomy that removes the ovaries, um, before the time when you might otherwise go through menopause. Having shorter periods, so 3 or fewer days, low parity, which means fewer or no pregnancies, smoking, of course, sedentary lifestyle, and eating highly processed foods. Um, and research shows that women with more severe vasomotor symptoms have higher cardiovascular disease risk. We went over that. Um, and then, if you're working with your doctor and having your cholesterol tested, we always recommend also checking a test called ApoB or apolipoprotein B, which is just actually like a more accurate, better test of the heart disease causing types of cholesterol. And those just do tend to increase with the transition into menopause. So that's probably one of the factors that's playing a role here, where if you go through menopause early, or just kind of have lower hormones in general, that is likely to contribute to more of these atherogenic, or that means um, cholesterol changes that are more likely to clog up the blood vessels over time. So, estrogen is the most effective treatment for vasomotor symptoms, meaning the hot flash type symptoms, night sweats, that sort of thing, where your blood vessels are kind of dilating and then constricting. As well as for urinary symptoms. and for preventing bone loss and preventing bone fractures. So really, one of the best treatments for preventing osteoporosis and preventing fractures is bioidentical hormone replacement therapy. Um, Osteoporosis, um, 1 in 10 women over the age of 60 will develop this condition, and 1 in 2 postmenopausal women will have osteoporosis. Um, and estrogen replacement is really our best option for treating that and really greatly reduces fracture risk. I want to talk a little bit more about delivery forms just so you have a sense of what's out there. We basically always use the bioidentical forms, not the synthetic forms. So that's what we'll be discussing. So the estrogen is available as a pill to be taken orally, as a patch to be applied usually 1 to 2 times a week, as a cream to be applied topically as well, or as a pellet, which gets inserted. Um, it's a very minor surgical procedure. You make a tiny incision in the hip and insert a tiny little pellet that is made just of hormones with a stabilizer, and it slowly dissolves over a period of months. Progesterone is available as a capsule to be taken orally, as a troche, which is like a little tablet that dissolves under the tongue, or an oil that has to be compounded, or as a topical cream. And then testosterone is available as a cream or as a pellet. Um, Estrogen is the big one where taking it orally does include some increased risk of blood clots, especially. So that's not a good option for anyone who has increased clot risk or smokes cigarettes because that also increases clot risk. The other ones don't have that issue. So someone with known cardiovascular disease would likely benefit more from the topical estrogen as compared to the oral. Someone with osteoporosis would benefit more, probably more from the oral versus transdermal or like a patch or cream. However, there are studies showing that the patch can be helpful as well. Um, there are not a ton of studies looking at the oral micronized progesterone, which that's what the bioidentical progesterone is called. Like say you were going to get a capsule from a standard pharmacy, it's called OMP or oral micronized progesterone. Um, but when paired with estrogen, there's less risk of breast cancer than with using topical progesterone. So taking the progesterone orally actually seems to have additional anti-cancer benefits over the topical. Um, Women who've gone through menopause and still have a uterus, they haven't had a hysterectomy, always for safety need to be, if they're going to use an estrogen treatment, they also need to be taking progesterone. That protects the uterine lining from overgrowing, or it's called hyperplasia, which is sort of like moving in the direction of uterine cancer. So taking progesterone with the estrogen prevents that. Also, oral progesterone is better for sleep. So, a topical form, um, applied to the skin helps with hormone balance overall, but basically none of that progesterone is going to get directly into the brain and help with calming, with anxiety, with sleep. So if those are some of the issues that you're having, then taking either a capsule or actually the troche that dissolves under the tongue or the oil that you put under the tongue work even better than the oral capsule for getting crossing the blood-brain barrier. Progesterone binds to our neurotransmitter receptors in the brain that are very calming. And so that's what our natural progesterone that our own bodies make does. And then same thing here with the bioidentical supplement form taken orally. Um, and just better risk reduction taking the oral progesterone versus topical. So I've very occasionally encountered women who have some side effects. It's quite rare with taking oral progesterone, and so we do the topical, or sometimes it's just like way easier. They just much prefer, don't like taking capsules or something. But in general, I kind of lean toward the oral forms if possible. And compounding pharmacies can even make a sustained release progesterone capsule, which can especially be helpful for sustaining deep sleep. So there's a lot of really nice options.
And I'm just going to close this topic with testosterone hormone replacement therapy. About 25% in women will experience a decline in testosterone postmenopausally, and about 50% it just kind of maintains in an optimal level. And then there is a 25% where it can actually just remain elevated even through menopause. And testosterone is important for mood stabilization. It helps drive sexual energy, libido and arousal, cellular energy, fitness, stamina, maintaining and building lean muscle mass. And then maintaining optimal testosterone levels is cardioprotective, and it does lower cardiovascular risk. The options for delivery in women are the topical creams or gels, which can also be mixed with other hormones. So when we talk about compounding pharmacies and customizing a bioidentical hormone prescription, we're often able to put the testosterone, estrogen, progesterone, sometimes even DHEA all together in a cream to keep it simple with a single daily application. So we have the topical and then the pellet delivery. So as Dr. Wood mentioned, the pellets is just the granulated testosterone or estrogen is an option that way. And it just provides the body a reservoir of that hormone so that it can pull what it needs on a day-to-day basis. It's a really minimally invasive procedure. And because of the effect of testosterone on lean muscle mass and the receptors in skeletal muscle, having an exercise routine and regimen, which is great for supporting menopause anyways, as we talked about earlier, actually really improves the pellet delivery and how long pellets last for women, which can be anywhere from 3 to 4 months. So, and that's muscle tissue that is highly vascular and likes to be worked and used. So,
All right. So how do you know if you would benefit? And to be clear, our goal here is just to let people know that this is an option and to dispel some of the fear around it. I also have patients who just they just don't want to do bioidentical hormone replacement therapy, and that is totally fine. And we work with diet and lifestyle and herbs and, exercise and all of that. And that provides wonderful benefits as well. So, but I have just encountered so much fear that is left over from that that study and all of the media attention around that has just persisted for so long. And so, I just feel like that's a disservice um, to be fearful of something when the research has moved on and shown us that it really is a safe option for most people. So we can do testing, and that can really help to understand who would benefit from hormone replacement therapy and how much, and just to monitor and adjust to make sure we're in a safe and optimal range. So we can check levels through the blood, through the serum, and we can check through the saliva. They kind of have some pros and cons. And, depending on which type of hormones a person is taking, one type of testing might be better than the other. But that can be so helpful to see where you're at currently and then to monitor the dose. And then also, a lot of times people come in, they're in perimenopause, maybe they have had a hysterectomy and they don't know if they're completely through menopause. So there actually are hormone tests called FSH and LH that help us to get a really clear picture of whether someone is fully through menopause or not. So that can also be useful. We can also test urinary metabolites of hormones, and that is not so useful for knowing where your hormone levels, like whether your dose is correct. But it gives us a lot of really detailed information about what each individual person's body is doing with their estrogens. So some people genetically have a propensity to convert their estrogen into higher risk forms or lower risk forms. So, that would be either protective or cause increased disease risk. And so that the urinary metabolite testing can give a lot of insight about that. And then there are some herbs and nutrients that can help, if someone is just naturally converting their estrogen into a higher risk form, there are some things that we can do to nudge it the other direction, get the conversion to go a different way into a lower risk state. Um, and our genetics and our diet also determine how our bodies break down hormones when we're through with them. So we can break them down in a way that's actually protective against cancer or carries a higher cancer risk. Um, in my experience, most conventional doctors don't offer testing of hormones. But we find it to be really useful. So that is something that absolutely exists and is available. And if that's something you're looking for, we would love to help you out with that. Do we have any questions? We're kind of nearing the end of our class today. Nothing popped up in the chat, but just want to ask one more time. Okay. Well, thank you for being here. And thank you again to the Olympia Co-op and to Monica for hosting us and just helping us share our passion and love of supporting women in the community. Um, we are offering a couple discounts in case there's anything that you wanted to try, whether it's one of coming in for a consult visit, trying one of our other treatments that we offer at Tummy Temple, which includes electrolymphatic therapy and colonics, and I do craniosacral therapy. So we're offering $20 off, or actually, I'm sorry, $30 off any 1 hour visit. You would need to book it in the next week, but you could book it for further out. You just have to call and make the appointment in the next week. And then 20% off for the next week of the products in our online store of the things that we talked about in the class today. So if there's anything that felt like it would be a really good fit for you to try, you're welcome to use that 20% off to give that a try. And Dr. Dowdy, did you have any last thoughts you wanted to share?
Oh gosh, I don't think so. Just thank you all for being here. You're all
Yes.
menopause experts too now.
Thank you for
So
being
look
here.
forward to
And
having
we
you.
typically send out a follow-up email. Oftentimes just it can be a couple days later, just whenever I get the email addresses from this class and the link to the recording. So yeah, we will send that out. Often typically it might end up being Monday. But keep an eye out for that. If you want to refer back to the class, the link should be included in there. And then we'll have the code for the discount code for the 20% off discount. And oh, I actually have a little write-up that just has like the names of the estrogen delivery forms, the names of the herbs that we talked about. So I will attach that as well. Hopefully that's helpful for you. And a little bit of info of upcoming classes and that sort of thing. So keep an eye out for that. Thanks again for being here. I hope you have a lovely evening.
Thanks, everyone. Thanks, Monica.
Thank you so much. That was super informative as always. Appreciate you.
Good night, everybody.
Good
Good
night.
night.